Okay, welcome to Spine Conference. Today's discussion will be how to prevent surgical site infections. So I got this email. This is what started this conference. I got this email 2 weeks ago. Dear Dr. Anginitis, in 2010, an estimated 16 million operative procedures were performed in acute care. Hospital-associated infection accounts for 31% of infections among hospitalized patients. Below, this case met the definition for deep incisional primary surgical site infection. It happened within 30 to 90 days. And why is this important? Because the government has labeled this as a never event. So a never event is the kind of mistake that should never happen in the field of medical treatment. And I think what's most important, this is they say it's largely preventable. Now, I don't think this is the same as leaving a pair of scissors in the abdomen. That is most definitely a never event. So anyway, I thought that was interesting. So I like to do case-based learning. So this is a 74-year-old woman with left sciatica. She has symptoms in the posterior leg to her lateral malleolus, which, Katie, what's lateral malleolus equals blank?
L5.
L5, yeah, automatic. She's failed injections, physical therapy, nonsteroidals. She has had previous L3, L4, and L4, L5 laminoforaminotomy decompression 12 years ago. So that's not bad that she lasted 12 years after a decompression. And she has bilateral total knees, rotator cuff repair. Her height and weight is 5 feet 5 inches, 267 pounds. So her BMI is 44. So she definitely has obesity. And what do you find on the x-rays, Katie? AP view?
On AP, she does have a little bit of scoliosis, but it's not
listing.
Too bad.
I would call it more listing. Because this is a standing view.
Okay.
And see, the spine is kind of listing. It's not curved. You can tell by the posterior spinous processes.
Okay.
And the lateral view?
On the lateral view, she has retrosthesis at 4.5.
Spondylolisthesis or anterolisthesis, if you want to call it.
You wouldn't call that retro 5 going backwards on 4? You call it
No, always. Yeah, always.
Okay.
I never even thought about that, but I've been doing it for so long I forgot how I do it. So
okay.
the top to the bottom, yeah.
Spondylolisthesis at 4.5.
Yeah, and
flattened disc height at 4.5.
Yeah, a little bit of kyphosis at 4.5 too, right? A little bit. See, that's a little bit. Yeah.
Little bit.
See how the front of the disc is a little bit smaller than the back of the disc?
Yes.
So I guarantee you that when I did the first surgery. When I did the decompression, she did not have a deformity. So she basically developed a deformity, but it lasted 12 years, which is 12 years is a long time, right?
Mm-hmm.
So risk factors for infection, tobacco, age, diabetes, revision. We're going to go over this: revision, surgery, alcohol, comorbidities, urinary incontinence, nutrition, which I have a theory, Walter, is most elderly people and most diabetic people have malnutrition. Because what do you think about that?
I think it's a first thing.
Because when you see these people, you don't think they have malnutrition, but I think they do.
Actually, they have problems with access to proper nutrition, supervision, and so on. But there's a social aspect of the aging process that prevents you to get the facilities of social convenience, of good nutrition, and so on, transportation, mobility, and so on and so on. I think it's a fair statement.
Yeah. So I mean, I, as a surgeon, as a doctor, I think I have to think about this because you don't think about it, but once they get the complication, then you send all the albumin, total protein, and then you realize that they're all so low.
They actually, the issues with the early, of course, comes with what can they digest. Because some of them, they get the simple diets where mainly carbohydrate intense. The protein digestion is more difficult when you go older.
Yeah.
Reflux and medications and all that stuff. I think it's a first step.
Yeah, so it's a problem that we have because if they're malnutrition, then they're at risk for infection. So other risks, neurological deficit, obesity, the approach, instrumentation. We'll get through all these. So here's our case. So sagittal cut, top left. You see behind the L4 vertebral body. What's that, Katie? See that density, like a disc fragment, right?
Yeah, I
And
just don't know if it's coming. I don't know which disc it's coming from.
yeah, this fragment, and then so I showed the axial cuts at 2, 3. Spinal canal is somewhat small, not very small, but somewhat small. 3, 4, definite hypertrophy here of the ligamentum flavum, compressing the thecal sac, which will give her sciatica. This large fragment on the left, which is probably her chief complaint. 4, 5, there's fluid within the facets, and the facets, this one especially, is kind of irregular. 5, 1 centrally is open, although potentially this could be giving her sciatica too. It's possible that this could be compressing the 5 root as it exits. So, you know, the problem in my mind is what surgery to do. I don't think I could just do a decompression because she has spondylolisthesis. Not only does she have spondylolisthesis, but she's kyphotic. I mean, if you look here, the end plates are kind of parallel, but if you look at the x-ray, it's not parallel at all. So it shifts from looking nice when she lays flat to very crooked when she stands. So it's a significant instability there. So I think you have to fuse that at 4, 5. And then 3, 4 looks pretty good. And I don't have the flexion extensions, but they were good. So this talks about infection, so I won't get into great detail, but my plan was decompress 2, 3, 3, 4, 4, 5, and then fuse 4, 5 because of the instability. Now, she had obvious risk factors. I mean, her body mass index is 44. If you look at the MRI and you measure from the skin to the L4 lamina, it's 9 centimeters. And if you look at the fat from the skin to the bone, I didn't measure that, but it looks like it's about 4 centimeters. So why is that important? So this on the right is a statue of me that I posed for several years ago. And this, why are you laughing, Katie? And this guy is probably 6 feet tall and 250 pounds, right? Is he obese? I mean, he's the same body mass index as the case we have. So would you characterize him as obese? I mean, no, right? He's like Hercules. So this study in 2012 and I'm sorry you didn't have it, I just sent it to you this morning, but this in 2012 is from Duke, and they measured not only obesity, but the distance from the lamina to the skin, so the fat, and also the muscle distance and the subcutaneous fat. And this column is infections, and this column is the control group. And you see that the distance from your skin to the lamina is much higher in the infections, and the subcutaneous fat is the distance, like 3 centimeters or 2 centimeters, is much higher. So if you have a layer of fat around you, you're more at risk for infection than if you're Hercules, but you have a big layer of muscle. And do you guys have any theories why? I have a theory. Anybody?
Of why there's
why are you at risk for infection if you have a layer of fat versus a thick layer of muscle? What's the difference?
Is it because there's more like crevices in fat, like all the little
There's more sebaceous.
yeah.
You have a cavity. You could develop like a cavity that fills with fluid. Yeah.
Redundant tissue, sweat, and sebaceous secretions actually are good culture media.
That it's a culture. Yeah, exactly. It's a culture media. So when we do the surgery, the fat dies very easily, although the muscle dies too, but the fat dies and becomes a big seroma. And that's like basically in microbiology, if you remember from school, that's how you grow bacteria. It's like a nice culture medium.
Yeah.
So it becomes a culture medium for infection. So not only the body weight is a risk factor for infection, but what is the weight coming from? Is it all muscle like Hercules, or is it a thick layer of fatty tissue, which can lead to infection like a culture media? So this patient it was kind of a big surgery. L4-5 fusion, right iliac crest. Actually, I did decompress 5-1, I'm sorry, on the left. So left L5S1, bilateral 4-5, left L4 hemolaminectomy, decompressed L2, L3 as well. She got 3 liters. Blood loss was 600 cc's. The operative time was 4 hours 50 minutes, which is kind of a long surgery. And I put vancomycin beads. So I think the surgery went very well, considering it was a revision, deep case, 4 levels to decompress. She did great, and I saw her post-op day 11 here. No complaints, walking around, wound looked great. I thought to myself, wow, I dodged this bullet. She did fine. And then she presented to the hospital post-op day 19. Now this is kind of interesting. She was septic. She had urosepsis. She had gram-negative rods in her blood and her urine, no fever, normal white count, draining pus from her wound. It's kind of interesting. She went to an outside hospital. So they called me. I said, just transfer her. I'll take care of her. And it turned out she had E. coli in her urine, E. coli in her blood, but her wound was growing MRSA. And she never had a white count, and she never had a fever. She just, as it's very common in elderly people, she presented in the emergency room because she's confused. She didn't know. So what are your thoughts about that? I have my own opinions, but what do you think?
I always believe that in that stage, we can see a lot of colonization of MRSA, but it's not until you have a superinfection that you get immunocompromised, because your bone marrow doesn't react the same way, specifically over the 6th, 7th, and 8th decade of life. That's what we always have as a good rationale for early people to get septic without the regular signs that you see in a younger person.
Yeah.
That usually get febrile.
Yeah, so if Katie had a urine infection, she would have a fever, she would have chills, and she would have dysuria, because she's young. But this woman had no symptoms. She just presented as confusion, which is
main symptom for that age range.
Yeah, it's very scary, and I think she's immunocompromised too, because she didn't mount a fever, didn't mount a white count. So my rule for infections is extremely low threshold to take her to the op room right away and just get rid of the problem. So that's what we did, right, Katie? Remember, we went, and it was, how would you describe the, do you remember the case? How would you?
Don't say the patient.
Yeah, we're not saying.
How long ago was this?
It was a while ago. It was the one that was like milk, remember? We opened superficial tissues like milk. I was like, wow, this person, she didn't even act sick. Yeah, and once she was on the antibiotics, she felt better. I was like, I can't believe this. She had this pocket of pus, and she didn't mount any infection, and no redness. No, it's like bizarre. It tells you how immunocompromised she was, and I think probably malnutrition. So any questions about this case? So the long term is, we're going to go over some articles. She actually did great. She did the antibiotic 6 weeks. She's fine. And I saw her back. She's like 3 months out. She's fine. She was infected superficially, not deep. So my standard is I open the skin, wash it out very widely, debride it, and then open the fascia and wash the fascia out, culture both sites. The deep site was not infected.
The antibiotic regimen was 4 weeks, 2 weeks IV, and then
6 weeks IV.
So you got a PICC line.
Yeah, because it just because she was immunocompromised, correct. And it was very purulent. So
was she resistant to other medications? Is that why she was on Dapto?
She's MRSA, methicillin-resistant Staph aureus. Okay. Yeah, interestingly, and she had E. coli.
Right.
Okay, so any questions about that case? So I'm going to go over some of the literature. I think is kind of interesting. So this is a meta-analysis from China. So they researched the English literature, which is kind of interesting, and it came from Tianjin, which is just southeast of Beijing, and it's a meta-analysis of epidemiological incidence of surgical site infection after spinal surgery, which is, it was just last month in the Journal of Spine. And so this is basically, what's the meta-analysis of surgical site infections in spine, meta-analysis. So pooled incidence is 3%, superficial 1.4%, deep 1.7%. Highest incidence for neuromuscular, which makes sense. Tumors, 5%. Cervical, 3.4%. Thoracic, 3.7%. Lumbar, 2.7%. Posteriors are twice the risks of anteriors. And I think, what's the theory? You guys have any theories why posterior would be more likely than anterior?
They can't see it. They can't see it. They can't actually treat themselves.
Yeah, they can't see it. I think it's maybe distance from the scan. I don't know. Nobody knows. Instrumented are a lot more, 4 times as common as non-instrumented. Minimally invasive and less than open. And Vanco powder helps. Vanco powder decreases it from 1.9, goes to 1.9% from 4.8%. So Vanco powder, they found that, review their literature, Vanco powder helps. Some other articles have found the opposite.
I'm just surprised that actually the incidence for cervical events versus the lumbar spine is above that.
I think that's posterior cervical drives that up more than anterior. They didn't break that down, but this includes also posteriors. So what were the bacteria? Staph aureus, Staph epidermidis, and MRSA was 23%. So almost always Staph aureus. Operative time greater than 3 hours was sort of like the breaking point. This patient was, remember, for almost 5 hours, so she was greater than that. Blood loss greater than 500 cc's. She met that criteria too. These are just the gram stains we talked about. Staph aureus was the most likely in MRSA. So any questions about incidence, 3%? This is the next article. Okay, so this is, out of all the ones I gave you, I found this the most helpful. It's from Paul Anderson in Wisconsin. So these are the risk factors they found. The most common: diabetes, obesity, revision, smoking, urinary tract infection, which our patient had, right? She had a concomitant urinary tract infection. Hypertension, transfusion, CSF leak, dural tear, blood loss, and age were not so high. And BMI was not so high, but they only looked at it as greater than 25 and less than 25. So they didn't really break it down to like 35, 45. So there have been other articles that showed like the higher your BMI, you get 30 BMI, 40 BMI, 50.
Transfusion is so high. The transfused issues is supposed to be sterilized.
Yeah, transfusion is definitely a risk. I think when you transfuse blood, patients become immunocompromised. Yeah, but we don't transfuse that often anymore. Almost never compared to 20 years ago. Almost never. So glycemic control. If the A1C is less than 7, nobody gets infected, and greater than 35%. So, and the joint replacement literature is 7.7, and that's from a recent review for the AAOS for joint replacements. So not for spine, but you can probably transfer that information to spine. And we don't routinely check hemoglobin A1C, but the primary care physician does. So getting smoking cessation has to be at least 4 weeks pre-op. And Katie, you've seen that if it's less than 4 weeks, they actually do worse. Like they sound like they're having an asthma attack. We talked about body mass index. So if you screen patients for MRSA pre-op and treat them for their superficial infection, it significantly decreases the chances of MRSA, which is 20%. So we screen everybody who has implants. So basically, I think that's a fair rule because the non-instrumented people are extremely unlikely to get an infection. And I found this on how to swab the nose because I was wondering how do you swab a nose? I found this on it was on an article for pneumonia, MRSA pneumonia, and how they tested the patients. And they put it in both nostrils 5 times. They swirl. I mean, I don't do that, so I'm going to start doing that 5 times. And you moistening it may help. Moistening it with sterile saline. So we should probably start doing that.
We'll let Dawn know.
Huh?
We'll let Dawn know. She does this.
She does it. And put your finger on the nose so you make sure you touch the outside of the nose. Yeah, the wall of the nose. And the treatment is mupirocin cream for a week and Hibiclens. But that significantly decreases basically the MRSA on people's bodies. Although it doesn't always work. I mean, you can, sometimes it takes 3 to 4 weeks of that to clear it, but we don't do that. We usually just do a week. So, so the antibiotics has to be within 30 minutes of the surgery, not more. So, not 30 to 60. So it decreases surgical site infections if it's 30 minutes. So it's the highest concentration in the blood system when you make the cut, you make the incision in the body, and redose every 4 hours, and you don't cover drains. The skin, I think there's no difference in this article between chlorhexidine scrub, ChlorPrep, or iodine prep, DuraPrep. But I use, for spine, Hibiclens is the best. I mean, they say, but for MRSA. But for joint replacements, iodine-based is probably better. It probably doesn't make a difference. But I do both. I do, because I'm paranoid, I do ChlorPrep plus the chlorhexidine prep. Scrubbing your hands is very similar to the skin prep. It doesn't really matter as long as you do chlorhexidine or the iodine-based for 5 minutes. Normothermia decreases surgical site infections, and the way we do that is the bear huggers. So double gloving helps decrease surgical site infection, and having a different color helps you notice if you have and that we do that. It's much better. You know exactly when you have a tear in your glove. And changing gloves before the implants is a good practice too, which I don't do because the first thing I do is put in implants. So it's not really relevant. But in joint replacements, it makes a big deal because you expose everything and then you change your gloves just before you put the implant in. The other thing, Katie, is you should remind me is like halfway through the case, I should change my gloves because it's just, you get like, it's caked with blood and it's just, and you may have a hole. So you should change your gloves frequently. That's one thing I could probably do better. We'll talk a little more about vancomycin powder. The other thing is, this is unclear if you should do this, but it's betadine irrigation. So if you dilute it some to 3.5%, it does decrease post-op infection in some articles. This was a 2005 article. I don't do this. I'm concerned about the dura, but I think in high risks, maybe I should. The irrigation. This, I didn't know about this, but they have Vicryls with antibiotics, and there's some evidence that it helps. So I called the hospital. I want them to buy them for me.
Okay, so we don't use those.
No, it's kind of new.
Okay.
Vicryl Plus.
It's a lot more expensive.
Of course it is. Yeah. It's not going to be cheaper.
But it's cheaper than
an
surgical
infection.
site infection.
Yeah. And then the other risk is oxygen. Is that intraoperative oxygen less than 50% is a surgical site infection risk. And this is from anesthesia literature, and I have no idea what they give. I have to start talking to the anesthesiologist. They probably do it, but I have to talk to them. I didn't know. And then plus or minus silver impregnated dressings to cover the wound. There's some evidence, but not a lot. And then incisional wounds vacs. So have you ever seen these, Walter? They're kind of new. So they started with big defects. So you have a big hole, and the hole takes forever to close. Yeah. So you want the hole because you want the pus to come out, but it takes a long time, and it's very difficult for the patient to pack. So they have these black sponges. You cover it with plastic, and then you put a vacuum on it so it sucks all the fluid out and also closes it through the vacuum. It works great for big defects. You know where they proved this is in Iraq, in Afghanistan, Iraq, with the soldiers. Yeah. Wow. Yeah, they had a lot of experience, and it really helped a lot. But this is an incisional wound vac. So if you think a wound is going to drain, like a very obese patient, you just put it over the wound. So it sucks all the fluid out until it closes. Wow. So I've done this a couple times just with infections. Okay, so any other questions about what we talked about? Comments? Okay, one more. This is intra-wound vancomycin decreases the risks of infection. This was a multi-center analysis from 2017. 2,000 patients over 4 years, 7 centers. And the vanco powder infection rate was 2% versus 5%. So it was a very big difference. And Their technique was 1 gram of vancomycin powder for every 10 centimeters, or for about 4 inches, and avoiding the dura on the bone graft so you don't cause a neuritis or affect the bone graft. This was prospective but not randomized. But interestingly, the people they put vancomycin were sicker and more obese and had more medical problems than the people they didn't use powder for, and they still did better. So basically, the surgeons put the vanco powder when they thought it was an at-risk patient, and they still had a lower infection rate than the healthy people. So it's a good fact. And the people with vanco powder did not go back to the operating room for infections. The other interesting point is that the vanco powder is gone after 4 days. So it's just basically it's in the wound for 4 days, and then it's gone. But that's by 4 days the wound should be closed. So that's a good article. So that's it. So this is a short conference, but
What is the ID guys' peers thought about pre-medication during this procedure? And patients that actually are relatively healthy, how they always get concerns about resistance to antibiotics and so on.
for vanco powder,
Banco powder, or even the
that study's been a couple people have studied that. Actually, my partner studied that the when people have vanco powder, what infections do they get? They don't.
And what is the rate of getting
A resistance.
resistance? Yeah, correct.
It hasn't happened yet, but when it happens, it's Armageddon. It's like we're dead, but it hasn't happened yet.
That's the last stand, Banco, man.
Yeah, if you're resistant to vanco, it's a national emergency. Yeah, it hasn't happened yet, but that's the fear. Yeah, but I mean, but what are you going to do? It helps people though. It's like
That's the
as a society, we're in big trouble. And the other problem as a society is that nobody's making antibiotics anymore because it's not profitable. So we don't have any antibiotics. We just have what we have. We don't have any new antibiotics. So when it happens, we're going to be in really big trouble. Like a lot of people are going to die if it happens until a new one comes out. Don't you think? I mean,
he's going to go.
Yeah, it's going to be very scary for years. Yeah. All right, what else? Any other questions or comments about preventing surgical site infections? Did you learn anything, Katie? I learned one thing, 1 gram for 4 inches, because we never know how much.
Yeah, that's true.
We always say, how many grams? I don't know, 2 or 3. 1, 2, 3. Remember, we always
What would be your cutoff for surgical indication? And, because we are an obese society.
yeah, what are you going to do? So
And that's the thing.
Yeah.
I mean, that's the eternal kind of conundrum. When do I stop? Because my procedure can kill you. You're obese, but you need that. I mean, you have somebody have a large herniation, cataguana, or whatever it is.
I'm doing it. I'm not going to let.
Have you ever turned someone
No,
down?
I'm not going to. Never. I'm not going to let grandma.
Never.
Well, no, that's not never. There's a couple. 400 pounds. It's the surgery is very difficult.
Yeah.
It's
difficult for the operator. It's difficult for the patient. It's difficult for everybody who's involved in the care of that patient.
It may not be worth it.
Specifically, the patient is a morbidly obese with no mobility. He's just dead down, but
Yeah, no,
Maybe it was the Anderson article, but one article mentioned seeking advice to go see a bariatric surgeon before this elective spinal surgery.